Okay, so resume. Select chest pain. Boom. See chest pain. Okay. Okay. You start ready? 3, 2, 1, start. Hello, welcome everyone. We will be talking today about acute coronary syndrome. So, acute coronary syndrome, we have outpatient acute coronary syndrome and we have inpatient acute coronary syndrome. What are the outpatient acute coronary syndrome? Stable angina, okay, or asymptomatic coronary artery disease. Okay, let's spell it. Artery disease. What are the inpatient acute coronary syndrome? We have unstable angina. This is an inpatient. We have non-STEMI and we have STEMI. Okay, so what are the difference between these? Like regarding pain, the first thing we get when we talk about pain, this one there's no pain, like the asymptomatic, so there's no pain, it's relieved by nothing, negative troponin, and there is no ST changes, okay, and the pathophysiology basically atherosclerosis of the coronary artery. While stable angina, usually pain with exertion, okay, and then what else? Relieve by nitroglycerin and rest. Is there any troponin in the stable angina? No troponin. Okay, so there's no troponin or ST changes. So here's my friend with me too, okay, or ST changes. So what are the stenosis in stable angina and asymptomatic coronary syndrome? Like what is the percentage of stenosis?
It should be less than 70%.
Okay, yeah, like between 70 to 90%. That's
okay.
What usually, okay, 70 to 90%, perfect. Okay, so this is for both, for the outpatient management. Okay, now how does unstable angina different from stable angina?
So the pain is present at rest.
Excellent. Pain is worsening and at rest. Nothing to relieve the pain. Would there be any troponin or ST elevation in unstable angina?
Yes.
No, there is no unstable angina. Okay, so there would be no troponin or ST elevation. Okay, it's just unstable angina. Basically, that's 90% stenosis had platelets on top of it. So on top of the problem, there's another problem, unstable angina.
So what's the pathology for unstable angina?
Basically stable angina is just having atherosclerosis of 90% of the coronary artery. But unstable angina, just there's a platelet, because what trigger the coagulation cascade? You have varicose striae, as we remember. One of them is endothelial injury. So this is atherosclerosis, 90% can cause endothelial injury due to the passage of blood. So that's why trigger more platelet accumulation. So it causes worsening symptoms, not relieved by rest. So it's about to have like the myocardium die. Okay, so this is a progression, natural progression of the stable angina. Okay, so now we have the non-STEMI. Okay, non-STEMI. What are the thing that you have? You have pain at rest. Okay,
You have
pain
troponin.
at rest. Okay. No, so this one unstable angina. Sorry, I had this. So the pain is worsening, but relieved at rest. At rest, because the myocardium is still not dead yet. So this is, sorry, my mistake. But the non-STEMI, you have pain at rest. Okay. What's the difference between unstable angina and the non-STEMI? What do you think is the difference?
So the difference is in terms of biomarkers, you will see troponin.
Excellent. So you have increased troponin. Perfect. So this is the non-STEMI. So this is natural progression. What is the pathophysiology for unstable angina and non-STEMI? Usually thrombosis, and you have less than 10% occlusion. Okay, usually thrombosis and less than 10% occlusion. Okay, so that's the non-STEMI. Now the STEMI, this is a progression, stable, asymptomatic. Actually, this should be number one. So asymptomatic, stable angina, unstable, non-STEMI, and then we have STEMI. STEMI, same thing, caused by thrombosis. So this one, let's just add it to the inpatient, because all of them thrombosis. Sorry. Okay, so let's put it first. Let's put it on top of that. Okay, yeah. So basically, thrombosis causes that's the difference between the inpatient and outpatient management. So STEMI, the STEMI, what is the difference between that? Still same thing. Pain
at rest.
At rest. Perfect.
Then we have ST elevation.
Excellent. That we have ST elevation. That's the only difference. Okay. What else do we have? Troponin. We could have it, or we may or we may not have it. So troponin plus minus. Okay, so these are the inpatient. Okay, so what are the things that we look for in the history? Okay, so when we go talk about history, so there are certain things that we gotta look for. Okay, so let's see, other stuff to diagnose. Okay, to diagnose the myocardium. Okay, so we go in the history. What do we find in the history usually? What do you think of presentation?
The patients coming with substernal chest pain.
Excellent. What else? Worse?
With a duration of 15 to 20 minutes.
Okay, and worse with exertion?
Worse with exertion.
And improve with nitroglycerin, right?
Or resting.
Yeah, or resting. Perfect. Or rest. Okay. So these are the three things. Okay, so let's see. Let's break them down into three sections.
So we can break angina pain into typical angina pain and atypical angina pain.
Excellent. So this is like let's see. So substernal, that's the first one. The second one is worse with exertion. The third one relieved by nitroglycerin or rest. So this one could be, if it's 3 out of 3, if they have all the 3, this is typical of the above. If they have just 2 out of 3, this is atypical. Okay, so that's the thing. What are the other things? Associated symptoms
like nausea, vomiting,
okay,
diaphoresis.
that's a good thing. Could be dyspnea, shortness of breath, diaphoresis, good, excellent.
Abdominal pain.
Could be presyncope. Let's focus on the most common one. Abdominal pain could be epigastric pain, maybe. Yeah, this could be present as well. So we look at the dyspnea, diaphoresis, and presyncope. These are the three important ones.
So if I go and explain the pain is located substernally, and the quality of the pain is dull, and the pain is radiating to either your left shoulder, your lower jaw, or and sometimes it can be unnoticed in case of diabetic patients.
Okay. What are the risk factors though? What are the risk factors? We have modifiable risk factors and we have non-modifiable. What are the non-modifiable risk factors?
Age.
Excellent. Age.
Sex.
More than 55 for women, sorry, and more than 45 for man. Okay, so we got a couple of years for that, so that's good. Family history too. Family history. If you have one of your relatives died less than 50, that's when it's positive. But if he died at 60 because of heart attack, it's not positive.
Genetics.
Yeah. So this is the non-modifiable. Let's make it summarize. That's, I think. What are the modifiable? Diabetes. What else?
Hypertension.
Smoking. Hypertension. What else?
Obesity.
Hyperlipidemia. Obesity. Excellent. What else? Vasculopathy. So these are the modifiable. You can just, if you don't stop smoking, eat healthy, okay, exercise, you decrease your risk factor for these things. Okay, now what are the physical symptoms? Physical symptoms, what are you gonna have usually? You gotta look for it that it's non-positional. Okay, non-pleuritic, this is important, and non-tender. You gotta look at these things, because if any of them positive, then you're wrong.
Then the origin of the pain is not the heart.
Exactly. So if it's positional, pericarditis. If it's pleuritic,
lungs,
pleurisy or something. Non-tender if it's musculoskeletal. So you gotta make sure it's none of these, and you add them to your notes. Would be good to add them to your notes. Okay, so what would be the natural progression for someone presented with chest pain? First thing, what do? We do 12 lead EKG. What do we do after that? Oh, sorry.
We first give, as per the ACLS protocol, we give aspirin.
Okay, but if we do, like, let's say you found on 12 EKG ST elevation, what do you do right now?
I'm gonna give the patient aspirin first.
Yeah, so we're going to talk about the medication. So the medications, so we'll talk about it. Monabash. This is obviously you're going to start that. Okay, it's called Monabash. Okay, which stands for
morphine.
What else?
Oxygen.
What else?
Sublingual nitroglycerin.
Nitro. Okay, what else?
Aspirin. Beta blockers.
Okay, beta blockers.
ACE inhibitors.
ACE inhibitors. What else?
Statins.
What else?
Heparin.
What else? Or clopidogrel. So these are the things. Okay, so you started him on, but let's say you started all of these, but then you found, what are the definitive treatment? That's what you're gonna do. 12 EKG ST elevation. Where do you take him?
We'll take
to the
for
cath.
the PCI.
Excellent. Cath. What if there's no ST elevation? What do you do? No ST.
We start with
elevation.
anticoagulation. We start with
like diagnostic wise, you do troponin. Okay. What if the troponin positive?
We will go with CA angiogram.
Yeah, positive. Then you go back to the cath. You go, if it's positive, you go do the cath again. Let me bring it back. Okay. So if it's positive, then you do the cath. You stop. What if the troponin negative then?
We will still go for the cath, because initially for first 6 hours the troponin can be negative.
Oh, we can do stress testing.
But the patient is already having the ST depression pain, so I will avoid doing the stress testing. I will definitely go for the cath to do CA angiogram, because I got ST depression on a 12
No, if
EKG.
there's no normal EKG.
If there is a normal EKG with nothing's
yeah, if it's like just a stable,
no changes on the ST wave,
no changes. Yeah, so then
we will go with the stress testing.
Stress testing. Okay, stress testing. What if the stress testing came back positive?
Then we will send the patient for coronary angiogram to locate.
Now you go back to the cath. What if it's negative? Then you rule out coronary artery disease. Okay. So first you go ST if there's ST elevation, positive, cath. If there is no ST elevation, you do troponin. If it's positive, you do cath.
So doc, I have a question.
Mm-hmm.
What if the patient has transient vasospasm of the coronaries?
Then if there is a transient, then this is different. It could be the vasospasm angina. This is different, treated by calcium channel blockers. Yeah, but right now we're focusing on the atherosclerosis pathophysiology. So that's the thing. So what do you do right now? What else would you do? Okay, now the cath. Let's say after we did the cath, we found out more than 3 vessels involved. What do?
We will send the patient for CABG.
Excellent, cabbage, CABG. What if it is less than 3 vessels?
And not including the main LAD.
Yeah, 1 or 2. What do?
Then we can go for stenting.
Stenting, okay. And then, what do you do, like with the stenting, after you start beta blocker, AC inhibitor? What do you need to do?
We have to start with dual antiplatelet.
Okay, excellent. It's called dual antiplatelet therapy. What does that involve?
It should include clopidogrel and aspirin.
Aspirin, yeah. Yep. Aspirin. And also put patients on high dose statin. Okay. Atorvastatin 45 milligram or rosuvastatin. Okay, anyway, I don't want to repeat the same
And doc,
thing.
I want to add one more thing. In clopidogrel and aspirin dual antiplatelet therapy, the duration should be at least 1 year.
Okay, that's a good point. Thank you for adding that. That's 1 year. That's a good thing. Another thing, what do? This is the things that we monitor, okay? What do? We monitor also with the monobash. We monitor troponin Q6 hours. And then what do we have? We have the 12 lead EKG Q 6 hours. Let me write Q here. Okay. And then
We can do the telemetry.
telemetry, perfect. They can do the telemetry. That would be helpful. What else?
We have to
Prophylaxis for low molecular weight heparin.
and SpO2 we have to measure. We have to make sure that arterial oxygen should be greater than 90%.
Oh, okay, that's perfect. That's good. There's a few notes for the stress testing here. For the stress testing, if somebody able to exercise, we do treadmill. If somebody unable to exercise, we do pharmacologic stress testing, nuclear, okay, imaging. But if there's a treadmill, we can just go do the EKG. That's one thing. Yeah, so for the stress testing, if there is if there is the risk factors and pain at rest and positive stress test, then the best way to do it is just to catheterize them. Okay, now that's basically in a nutshell the chest pain. So let's just do a quick summary of what's going on here. So as we said, outpatient management and inpatient management. Outpatient, the difference is that there's pain with exertion relieved by rest, and there's just atherosclerosis. The inpatient, there's thrombosis. Unstable angina, there is no troponin or ST elevation. Non-STEMI, there is troponin. That's the difference. And STEMI, there is ST elevation from its name. Okay. After that, we gotta look at the history, which we have these three: worse with the substernal, worse with exertion, improve with rest. If 3 out of 3, typical. 2 out of 3, atypical. And look at the associated symptoms: dyspnea, diaphoresis, syncope. Look at risk factors. There's modifiable: diabetes, smoking, hypertension, hyperlipidemia, obesity, vasculopathy, and non-modifiable: men more than 55, more than 45, women more than 55, like the age, family history. And the physical exam, make sure that's non-positional, non-pleuritic, non-tender. After we do all of that, Then we do the 12 EKG. We take the history. By the same time, we can do the 12 EKG. If there's an ST elevation, we do cath. If there is no ST elevation, we do troponin. If troponin positive, we go cath. If negative, we do stress testing. If stress testing positive, then we do cath. If negative, then rule out coronary disease. After we do the cath, if there's more than 3 vessels, cabbage. If there's less than 3 vessels, stenting. After we stent, we do dual antiplatelet therapy, clopidogrel plus aspirin. I like the name of clopidogrel, like sounds fancy, I don't know why. So, in the same time, we gotta treat him with monabash, which include morphine, oxygen, nitro, aspirin, and BASH stand for beta blocker, ACE inhibitor, statin, heparin,
Doc, this
plus clopidogrel.
This mnemonic reminded me of Bashing Mona.
Bashing Mona, okay.
So we are Bashing Mona. Is this a woman?
Okay, that's interesting. Okay. And then we gotta monitor the troponin every 6 hours, 12 lead EKG every 6 hours, and telemetry, and consider the low molecular weight heparin. And that's the summary of chest pain, acute coronary syndrome.